Dr. Rosen is a behavioral neurologist and holds the Dorothy Kirsten French Foundation Endowed Professorship for Parkinsonian and other neurodegenerative disorders. He received his medical degree from Boston University School of Medicine. He did his internal medicine internship at Albert Einstein in New York, and then subsequently did his neurology residency here at UCSF. After residency, he did his fellowship in brain imaging at the Washington University School of Medicine, and then returned to UCSF to join our faculty in 1999. Dr. Rosen's primary research interest is the effects that atypical neurodegenerative diseases, in particular frontotemporal dementia, have on the brain, and he's here to talk about that today.
Thanks, Courtney. Thanks everyone for coming. Gil mentioned that we have lots of young scientists and established scientists talking to you today. I think it's pretty clear which category I'm in. I'm going to talk to you a little bit about FTD, frontotemporal dementia. First, we haven't talked that much about FTD, so I thought I would just give one slide brief introduction. Frontotemporal dementia is a neurodegenerative disease. So in that sense, it is like Alzheimer's, but it's very different than Alzheimer's in many other ways. It's caused by a different set of proteins, some of which were mentioned by Courtney and maybe Stefania and Gil, I'm not sure who mentioned what. But, and those proteins include tau, but also this other protein, TDP43. And there are some other less common protein causes of FTD, but these are the main ones. And it causes a different set of symptoms. One thing I didn't remember to put on the slide is it affects patients at a younger age than Alzheimer's typically does. So, for example, people wonder how common FTD is. We think when you look at all causes of dementia, FTD is not that common. It's maybe 3 to 5%. But it's really hard to know because it's difficult to diagnose, as I'll talk about. But when you go to the younger age group, people under age 65, it's as common or possibly more common even than Alzheimer's. So it's a very important cause of dementia in people who face that challenge when they're younger. And the symptoms are different. People come in with FTD because of changes in judgment and abilities to plan things, changes in social and emotional behavior, sometimes seen as a personality change, changes in language, and changes in movement. So for instance, that PSP, progressive supranuclear palsy, that Courtney mentioned, that's a form of FTD that presents with movement dysfunction. And the semantic variant that you mentioned also, that's a form of FTD that presents with language changes. And there are other changes. The personality type things are the most common form of FTD. So what's new in FTD? Well, I think one of the biggest outcomes of the work we do is that there's a lot more attention being paid to FTD. And this is sort of AI confirmed. I double-checked this this search that in the last year and a half, there's been about 2,000 publications about FTD, and I thought I would just go through them one at a time, sort of a minute each. You have time for that, right? So of course, now I'll have to summarize. I think one thing is really just one slide on therapeutics. Courtney just mentioned a few of the therapeutic developments that are happening in FTD. This is a paper from a couple of years ago that highlighted 50 different potential therapies that are in development at various stages. Some very early in the preclinical, animals and cells, and some, quite advanced to the point where they're really being tried to see if they're effective or not. And they cover a variety of different approaches that you've heard about. Little molecules that can get into the brain, sometimes escorted, that's the Denali approach, but it helps to get those molecules in. Some with antibodies, similar to the treatments that we're using for Alzheimer's. Some with gene therapy, and that ASO that Courtney mentioned, that's a kind of gene therapy. Brain stimulation things, so these are not meant to draw out the proteins necessarily, but ways to help the brain function better with magnetic stimulation and things like that. And even speech therapy, which is a well-established therapy in stroke and other kinds of acute and then stable brain injuries where people are expected to recover to a degree. But speech therapy and other kinds of physical and occupational therapy have often been sort of neglected in neurodegenerative disease because we worry that people are going to get worse. And now we're finding that no, in fact, those kinds of therapies can be helpful for people with aphasia. So there's a long list of things being tried. And so what I wanted to focus on a little bit is, as those therapies are developing, what are we doing in research along the way? And a lot of that work is meant to help those therapies succeed as they're ready, right? So the two areas I'll focus on is some new stuff about diagnosis, and just with a couple of examples of each. If you're going to, apply a new therapy, right, you have to be able to diagnose the disease so that you're giving the right therapy to the right person, and you have to diagnose it as early as possible because as these proteins accumulate, it's logical and the data seem to be confirming that the earlier you start, the more chance you have of having an effect on the process. And then the other thing is, if we want to know whether a drug's working, the better we can track each person and how they're doing, the easier it will be to see if the drug is working. So as just a recent example of the diagnostics, one of the challenges we have is that when people have these emotional and social and personality changes, they're often interpreted by their physicians and psychologists and families as a personality change related to something like a psychiatric illness. And many of the symptoms overlap. And so it's been a real challenge to try to figure out what kinds of tools can we bring to health practitioners so they can separate that. So this is an outcome of work we've done over the last few years here, where in addition to enrolling people with FTD at our center, we've also kept an eye on people who we initially thought had FTD, but turned out not to have that, to have a not neurodegenerative cause, as well as we started enrolling people who we don't think have a neurodegenerative disease, but rather do have a psychiatric illness, mostly depression, but could be bipolar. And what this analysis did is try to say, what tools can we use to separate people who might just have similar symptoms, but from a non-neurodegenerative cause like psychiatric illness from FTD. And two tools that came out of this analysis were this protein called neurofilament light chain, which is not very specific, but it's a good indicator of whether the brain, the nerve cells are starting to be injured and they release this neurofilament. And so it turns out that it doesn't help us, let's say, know if somebody has Alzheimer's versus FTD, but it does help us know if somebody has neurodegeneration versus not neurodegeneration. And when we combine that with the MRI, you've heard several times, again, MRI is not super specific, but if you look at how much volume loss there is, how much the brain has shrunken over time, and things like that, it can help you know how healthy the brain is in general. And this combination, neurofilament light chain and MRI, was about 86% accurate in separating people who had FTD from non. And basically, everybody in red, everybody who's a circle on this graph, was accurately placed by the MRI. And if you can look closely, you see a few little X's there. Those are the only cases that were sort of misclassified using this approach. So that's an analysis that hopefully will come out in the next few months. It's under review right now. I'm really giving you hot off the press stuff. Here's another example. This is published, and it's very early in the sense that it needs to be continued to replicate it, but this is another example of another kind of biomarker. This is a measurement in blood using these things called extracellular vesicles or exosomes. So you'll be able to tell now that I'm not a bench scientist, and I'm going to talk about this in a very simple-minded way, which is what I imagine happening is, that these nerve cells and parts of the nerve cells are right next to blood vessels, and they have these little bubbles that pop off of them and have proteins in them, and some of those little bubbles make their way into the bloodstream, and then if they make it into the bloodstream, then you can measure them. And if you analyze them really carefully, you could say, well, these bubbles came from the brain. We can tell by what's in them. And then you could look for other proteins that shouldn't be in the brain. And essentially, there are some investigators who've shown that if you look at these kind of blood, these little bubbles floating around in the blood, you can actually see that there's TDP43, that should not be there. This is one of the FTD proteins, or tau. I'm really highlighting, this is early, this is one of the first studies that's really convincingly showed this kind of work might be effective, but it's just an example of where things are going, and you know, all the work that you all do here contributes to these kinds of findings. The graph on the left is meant to show the bubbles falling out, and the graph on the right is just showing, in this case, the TDP-43, which was high in people with Lou Gehrig's disease, or ALS. That's another disorder related to FTD, and this BV-FTD, the behavioral variant that I've been talking about. So another thing that's happening, which really also relates to trials, is that we've developed these large studies to try to understand how to track the disease over time. And ALL-FTD is one of those studies, which were the top enrolling site and also the lead site to organize this study. And it started, you know, about 10 years ago, and it's now grown to 28 sites. And thousands of participants have enrolled in these studies, most of whom have contributed MRI, or blood, or cerebrospinal fluid, or all of those things. So we've amassed a large data set, and that allows us to know about people all over the country who potentially can enroll in these studies. It also brings in centers that maybe were not so interested in FTD in the past, but now that they've come to be part of this community of researchers, they're more aware of it, more able to diagnose it. So there's a lot of benefits besides just the data. And one of the other things that this study is focused on is enrolling people with those mutations that Courtney briefly mentioned. So about 20 to 30% of FTD is due to a genetic abnormality that puts people in such a family at very high risk. And so in those families, sometimes there's people who carry the mutation, and sometimes there's people who don't. And the people who carry the mutation are at pretty high risk to get FTD. And the advantage of focusing also on families like that is then we can bring in patients who have the mutation but don't have any symptoms yet, as well as people who already have symptoms, and even people from the same family who don't carry the mutation. And so that's how we focused the study. And so in fact, we enrolled all of those kinds of participants in the study. And we're continuing to do those studies. And what that allows us to do is get a whole picture of the biology of FTD from the beginning, before people have any symptoms, and going forward. And so this is an example of an analysis we did. This one's getting pretty old, 2022, but now we're refining it and expanding it. And you can see in black is the changes over time on that same clinical dementia rating scale, some of the boxes that Gil mentioned earlier that we use to study Alzheimer's. This is a modification of it that we use to study FTD. And you see that people start to develop symptoms. Their CDR, some of the boxes score goes up. And what we've been able to discover is that it looks like maybe some of these same markers that we've talked about, like neurofilament light chain and MRI, might tell us just a few years before that something's about to happen. And I won't go into the details. That kind of information is really important for clinical trials because this is the earliest time that you can intervene without putting somebody at risk who's many years away from having any symptoms. And along with that, we've done a lot of other analyses that also are looking for new and more sophisticated predictors. A lot of this work I'm showing is using various protein measurements from the kind of proteomic work that Rowan was talking about earlier. And in fact, here's one of Rowan's papers right there, and other papers that are basically saying if we look at certain kinds of proteins, we can see that what we perceive to be a more healthy level seems to predict a slower decline in people who are at risk versus a less healthy looking level, a faster decline. And in fact, and another kind of measure we could do is to look and see, these proteins seems to start changing as people are starting to develop symptoms. So all of these can be worked into the models. And the last thing is, as you all know, doing this kind of research involves coming to a center like ours and getting very intensive treatment. And for all the reasons you've seen, that's highly valuable. But at the same time, we don't want to make everybody always come to our center anytime we want to know how they're doing. And so we're doing a lot of work to try to develop tools to monitor people at a distance, and then so that we can know how they're doing even within a trial for some of the time points, whether they've changed or not, and how much they've changed. But also people who we might want to follow for many years because they have a risk, but we don't want to bother them to come in. We can develop tools to check on their memory and other functions, and to check on how they're feeling using things like your cell phone. And these kinds of procedures are in the early phase, but we know, at least from working, that these kinds of, we've developed an approach that's acceptable to people, they don't find it too burdensome, that it's pretty reliable if you measure things once and then you measure them 2 weeks later, they're very highly correlated. And we're starting to see evidence that these tests are really pretty sensitive, so even in people who carry these FTD mutations but don't have any symptoms, they look a little different on these tests compared with their family members who don't carry the mutation. They're fine, but it just shows how sensitive these tests are. So, and the last thing is, I think you've seen several examples where collaboration across the world is needed. That's particularly true for diseases that are less common, like FTD. And those collaborations are happening. The paper I showed you with the graphs and the models, that was from a collaboration with a large European network that's similar. And now we're really trying to establish those collaborations beyond that across the globe. And that'll really accelerate discovery. So really, these are the conclusions. FTD is getting a lot more attention over the last few years. There are more treatments that are being tested, and that these large-scale collaborative networks are helping to define the whole course of the disease, which is what we need for diagnosis, prediction, and monitoring to help those treatments come to fruition. That's it.